Bismillahirrahmanirrahim. So it's a wonderful afternoon and it's sunny today. And let's start the talk. Today, our topic is chronic coronary syndromes. And basically, this clinical presentation is part of the larger effort of the PCS for dissemination of the guidelines to the clinicians. And this does have an excellent practice-changing impact for all the clinicians and to achieve the final main goal, which is better patient outcomes. So what is chronic coronary syndromes? As we all know, coronary artery disease has a huge burden worldwide, and the developing world is at the hit list because its burden is increasing day by day. So chronic coronary syndrome basically is the main cause is atherosclerotic coronary artery disease, and it's a pathological process which is characterized by atherosclerotic plaque accumulation in the epicardial coronary arteries, and the disease is chronic, most often progressive, and hence it has serious consequences. The good thing is that the process can be modified by lifestyle modification, pharmacologic therapies, and invasive interventions, which are designed to achieve the disease stabilization or regression. So the goals of today's presentation is to define the chronic coronary syndrome, CCS, to understand and clear the ambiguity among various terms which are used for CCS, and to have an oversight into the complication and potential risk if we leave this untreated, and what are the guideline-based recommendations for diagnosis and management, and what's new in the recent guidelines. So you see this graph. If we leave the chronic coronary syndrome untreated, or if the patient or the clinician do not pay a good attention, you see the bottom line is those patients who remain stable and who are well treated, which is the green part. And we see that in this scenario, let me highlight this one. So if we leave these patients untreated, these patients have recurrent episodes of ACS, hospital admissions, revascularizations, and the mortality is very, very high due to, death, MI, dysfunction, or arrhythmias. And if these patients are well treated and remain stable, then there is a huge difference or improvement in the mortality over time. So what's the terminology? Previously, stable ischemic heart disease was the terminology used by the AHA for this disease process, but currently the chronic coronary disease or chronic coronary syndrome, that is the standard terminology. So various other terms have been used in the past, which includes stable CAD, stable coronary artery disease, stable ischemic heart disease, chronic stable angina, or stable angina pectoris. These were all the terms which has one and the same meaning, and currently the standard term for all this is CCS, chronic coronary syndromes. And other than CCS due to atherosclerosis, in cases where anginal symptoms exist in the absence of obstructive coronary artery disease, then microvascular angina and prismatal angina. These are the only two separate entities other than the obstructive coronary artery disease, which would be included into the chronic coronary syndromes. So what's the definition? As we all know, it's a clinical syndrome characterized by constricting discomfort in the chest, neck, jaw, shoulder, or arms, which is precipitated by exertion or emotional stresses and relieved by the rest or vasodilators. The commonest cause for this syndrome is atherosclerosis itself. And as we will use this terminology, obstructive CAD, it means a coronary artery disease where the epicardial coronary has a stenosis of 50% or more, and non-obstructive CAD means less than 50% stenosis. So how to diagnose this disease? So there is no single test to diagnose this disease process. Basically, the diagnosis is based on the good history and clinical evaluation. That is the first step in the evaluation of these patients. And angina is called stable when it is not a new symptom and when there is no deterioration, if you can see duration or severity of the episodes. So this is added over here to differentiate from the ACS. So this table is a good clinical tool to diagnose the angina and classify the patients into typical angina, atypical angina, and non-anginal chest pain. So when a patient presents with chest pain, we have to evaluate and ask all these questions about the chest, nature of the chest pain, the cite the duration, frequency of episode, aggravating and relieving factors, and when there is constricting typical discomfort in the center or front of the chest with the radiation in the neck, jaw, or shoulder or arm, and it's precipitated by exertion and relieved by rest or nitrates within 5 minutes or so. So then this is called typical angina. And when only two of these factors or typical parameters are present, then it's called atypical angina. And when one or less than that, these symptoms are present, then we label it as non-anginal chest pain. For example, a patient who presents with central chest pain, which is aggravated by exertion and relieved by sublingual nitrates, then it's typical angina. So the clinical diagnosis is complete for a typical angina, and then we have to work up for that. But if a patient presents with a central chest pain, and which is aggravated by emotional stress or physical activity, but the nitrate does not have any impact and it does not have a typical radiation as well. So then it comes under the definition of atypical angina. Still, these patient need workup, but if the typical angina is not there, but it's atypical, but we cannot exclude the coronary artery disease. If only one of the parameters is present, for example, if patient presents with the central chest pain, but it does not have any relationship with exertion or taking of nitrates and does not have a typical radiation, then probably it's a non-anginal chest pain. And when an angina or CCS is diagnosed, then we have to grade the severity, because those patients who have increased severity, then these needs invasive and early workup as well. The patients who have angina, which occurs only with sternus activity, that is grade 1. With moderate activity, if the symptoms are there, then it's a grade 2. And with mild exertion, if the patient becomes symptomatic, then it's a class 3. And angina at rest is called a class 4. These two are the dangerous or red zones. Okay, there's another categorization of the chronic coronary syndrome by the European Society of Cardiology, and which is especially important in the patients, in the clinicians who are practicing interventional cardiology as well. So this categorization is important for those patients. So the category 1 is those patients who are diagnosed or have suspected coronary artery disease, but the symptoms are stable and they are newly diagnosed, but the symptoms are stable. They are put in the category 1. The category 2 is those patients who have new onset of heart failure or who are diagnosed to have LV dysfunction because of the coronary artery disease, but there is no ACS previously, and in the current workup with ECG and troponin, there's no ACS. These patients are categorized in category 2. Category 3 are asymptomatic or symptomatic patients. Category 3 and 4 are basically related to an episode of ACS or revascularization. So those patients who get an episode of ACS or who get revascularized for an ACS, and the duration of that is less than 1 year. So these patients are now included into category 3, and those patients who underwent revascularization and kept on taking the treatment, but the duration is more than 1 year. So these are taken to category 4. Category 5 are those patients who are having angina or chronic coronary syndrome in the absence of obstructive coronary artery disease. So these are patients who have suspected vasospastic or microvascular angina. So when the coronaries are non-obstructive, but the symptoms are typical and there can be documented ischemia as well, then this is a category 5. And category 6 are those patients who are detected as having coronary artery disease on workup due to another problem. So these are asymptomatic and these are detected only on screening. So these are the 6 categories. These are important for when we are doing trials or studies and when we are evaluating the efficacy of certain lifestyle modification or drug. So then these categories are important and these categorizations are used for study and research purposes. So next is how to evaluate a patient. We already discussed after clinical, history taking, good clinical examination, including the vitals, blood pressure, heart rate, periodic examination, and systemic signs of atherosclerosis. These after clinical examination history, these clinical signs should be sought. And when history and clinical examination has been done, then there are certain investigations which have a beneficial role. So on initial presentation, it's important to rule out PCS. So ECG at the baseline would be resting ECG would be done in all the patients, and a troponin should be done in all the patients. A serial troponin can also be done. So if there is nothing to suggest ACS in the ECG and troponins, then we label these patients as CCS, coronary syndromes. And then the next workup would include a baseline full blood count, including especially HB, a renal function test and estimation of the GFR, a lipid profile segmented, and screening for the risk factor like diabetes is important. So, what are the next steps which we take in the management of these patients? And what are the role of other testing techniques? Like, what's the role of Holter? We will briefly discuss this. Ambulatory ECG monitoring with Holter is recommended in patients with chest pain and suspected arrhythmia. So, and the ambulatory ECG, it's a class one. And the Holter monitoring can also be considered in patients with suspected vasospastic angina. So, in those patients, who have suspected vasospastic angina to document the STT changes. So we can do a Holter, and in patients with CCS, in order to document the arrhythmias, we can do a Holter. So the for diagnosis of atherosclerotic coronary artery disease leading to a stable angina, there is no role of Holter as such in these cases who have angina due to atherosclerosis. But in patients who have a vasospastic angina, then in these cases, the Holter is important to document STT changes. Okay, what's the role of echo? Echo is extremely important. So in patients with stable coronary artery disease or in patient with CCS, resting echo is recommended as a class one in almost all of the patients. How would it help? It will exclude the other causes of angina. It will identify any regional valve motion abnormalities. It will identify the LVEF, and it will also, last but not the least, it's important for evaluation of the diastolic function as well, which is so important in the management of these patients. Okay, so echo is a class one recommendation in all of these patients. And regarding ultrasound of the carotid arteries, previously there were studies in which the interval bleeding thickening was important to diagnose, but it has been seen the ultrasound of the carotid can be done in patients who have CCS in order to detect plaques in the carotid artery. So if carotid artery shows significant plaques, then there is indirect that significant present. So there is one very important question in these patients that which patients should go invasive testing and which patients should go non-invasive testing. So that is the question every patient would ask to us when we diagnose these patients with CCS, whether I need a coronary angio or not. So there are a huge list of tests which can be done, which includes CT angio, PET scan, and then invasive angio itself, and other, stress testing like stress echo and MRI. They're also available. But let us see which tests are important. So this slide shows the pre-test probability of obstructive coronary artery disease in patients who present with chest pain. So if we see at this, if the symptoms are typical and with advancing age. So anybody who is, you know, 50 plus with typical anginal symptoms, there is a huge, incidence of presence of obstructive significant coronary artery disease. And with advancing age, you see with every, switching from fifth to sixth decade and seventh decade, this, occurrence of the significant or severe coronary artery disease keeps on increasing. So it's important to know that the patient's age and the typical symptoms, if these are present, especially in the men, so then we should, go for invasive workup. If a patient is young patient and does not have typical symptom, then the chances of presence of obstructive coronary artery disease varies from 1 to 3%, as you see in the top line. Okay, so what would be the most mode of testing? This slide appears to be complex, but if we first focus on this one, the green one means the clinical likelihood of any test that it will rule out the coronary artery disease, and the red line means that a test capability to rule in the coronary artery disease. So if we see that coronary CT angio, it has a longest green line. That means if the coronary CT angio is normal, then the likelihood of obstructive coronary artery disease is extremely low. So coronary CT angio is an extremely helpful test in moderate, patients who have angina, and there appears to be at a moderate risk with normal troponin and normal ECGs. So if this test is normal, so the incidence of or the chances of presence of obstructive coronary artery disease are extremely low. And if we see at the PET and the stress CMR, they have the highest capability to detect a significant coronary artery disease. So they are there to rule in. If we want to rule in, if we want to rule in, the CT has a reasonable, but the SPET or MR has the highest capability. If we want to rule out, the coronary CT angio has the highest capability to do that. So what is the indication of guideline-based indication of invasive angiography? Invasive angiography is basically recommended as an alternative test to diagnose coronary artery disease in patients with a high clinical likelihood of typical anginal symptoms, and if the symptoms are severe or refractory to medical therapy. And in those patients where we suspect that the typical angina is present at a very low level of exertion, again, in these patients need invasive workup. And it's very important, as we see in the new guidelines, that with the invasive angiography, ideally, FFR or IFR should also be available. So because if FFR and IFR is available, and then we see that if it's significant, then we have to revascularize these patients. If FFR or IFR is not available, then a very high grade stenosis, like more than 90%, that should be treated, and less than 90%, they can be subjected to FFR or IFR. And so it's an investigation patient with suspected coronary microvascular angina. So when we have some patients where the patients have typical symptoms, central chest pain, aggravating with exertion, typical radiation, and relieving with the nitrates or rest, then this is a very typical patient. But sometimes when we do angiography in these patients, especially in the females or young or middle-aged males, and we see there's no obstructive coronary artery disease, the LED or right or left circumflex shows only mild coronary artery stenosis, but the typical symptoms are very typical. So in these cases, it's very important to rule out microvascular angina. And the test which is recommended to rule out microvascular angina is guide wire based CFR, coronary flow reserve. It can be used to detect the microcirculatory resistance, and if it's increased, then there's a diagnosis of microvascular angina which is established. And if we in some of the other cases, in the next slide, we see the patients have typical chest pain and typical symptoms, and their STT changes as well. But when we do the angiogram, there's no obstructive coronary artery disease. So these patients, as we already discussed, should be suspected of having vasospastic angina, and a Holter monitoring to document the STT changes while the symptoms are there should be done. And moreover, an invasive angiography can be done in these patients. And while doing invasive angiography, we can rule out, we can do intracoronary provocation test by use of acetylcholine or its derivatives. And if it's positive, then a vasospastic angina, diagnosis of vasospastic angina is established. Okay, after having overview of the basic workup of the stable coronary artery disease, CCS, vasospastic angina, microvascular angina, we will briefly discuss the management. So in the management, the revascularization by intervention or stenting comes at the end. The basic, the pillars of management are lifestyle modification, smoking cessation, healthy diet, improvement in the physical activity, healthy weight, then is drugs, and then is revascularization. Regarding smoking, so all the pharmacological behavior and non-pharmacological measures should be done, and all the effort should be done to convince the patient to quit the smoking. And as we all know, healthy diet is extremely important, which should be rich in fruits, vegetables, whole grains, and there should be less than 10% of the total intake with the saturated fats or unsaturated fat. Regarding physical activity, 30 to 60 minutes of moderate physical activity on more than 5 days is extremely beneficial, and the patient should maintain a healthy weight, which is less than 25 kg per meter square for the average height patient. Okay, the purpose of putting this table over here was that these are the don'ts and do's for all of our patients and even all the individuals who are at risk of coronary artery disease. And if we see that rather we're spending leisure time in sitting and watching TV, so walking a dog or walking in the park or doing cycling, so rather than using a lift, use the stairs, rather than having discussions or meetings and it's sitting on the discussion table. It's important to walk along and discuss your business or work matters while you walk along. So just by doing these changes in your layer activities and the working at your job, if we adopt these measures, there's almost a 10% decrease in the mortality due to cardiovascular disease. So the small changes in the lifestyle, they translate into huge changes in mortality benefit. So we'll not go into the detail of healthy diet characteristics, but we have to convince our patients. We can provide some charts or helping aids. So regarding drug therapy, there are drugs which are used to control the symptoms, and the second purpose of drugs is to improve the morbidity and the mortality. So regarding control of the symptoms of the angina, in these patients, for controlling the symptoms of the chest pain or angina, beta blocker and CCBs, they are the step one. Either of these drugs, and probably currently, if there's no compelling indication, then the CCB is the first choice in the current guidelines. And if the patient is not controlled with that, then we can add a beta blocker into that. And if the patient is not, the angina is not controlling even in the combination, then we add the second line drugs, which will long-acting nitrates, and then the third line, which will include ranolazine, trimetazidine, and these drugs. So this is the standard therapy. The second column shows the patient who have a angina and high heart rate, which means heart rate, baseline heart rate more than 80. In these cases, beta blockers would be preferred over CCB. And in the second step, a combination would be made. And the third step, along with beta blocker, ivabradine would be added if the still heart rate is high. In the patients who have a low heart rate, then as a first line, beta blocker would be avoided, but the CCB, the current standard is a amlodipine, that would be the first choice. And then we can switch to, if still the angina is controlling, we can switch to long-acting nitrates, or we can do a combination of these. In the low heart rate, beta blocker and ivabradine, they should be avoided. And ranolazine and trimetazidine, these are the fourth step of the treatment. And in those patients who have CCS plus LV dysfunction of or heart failure, again, beta blocker have a mortality benefit, so and angina controlling effect as well. So they would be the first line, and beta blocker along with long-acting nitrates or ivabradine, they would be the next in the line to control these. And sometimes the patients who have CCS but have a blood pressure on the lower side as well, like 100 or around systolic blood pressure on 100. In these cases, giving calcium channel blockers can further lower the blood pressure. So a low dose beta blocker can be used, or a very low dose CCB can be used. And these patients should be monitored very closely for the fall in the blood pressure or postal hypertension. And if it's not controlled, then the combination of 2 or 3 vasodilator is not appropriate. Rather than we have to switch to ivabradine, ranolazine, or trimetazidine. So regarding indications for antithrombotic and antiplatelet therapy, aspirin is recommended in patients who have a previous MI or a revascularization, and clopidogrel is an alternative to aspirin in patients where the aspirin tolerance is not there. Those patients who have undergone revascularization for at least 6 months, dual antiplatelet should be carried out, and later on single antiplatelet can be continued. Those patients who have CCS along with peripheral arterial disease, in these patients, clopidogrel can be preferred over aspirin. And in all those patients who have aspirin intolerance, again, clopidogrel as a single dose can be preferred. In those patients who are very, very high risk, for example, triple vessel disease, which is not revascularizable, and who have a CCS as well, then aspirin along with clopidogrel, DAPT can be continued even in presence of stable CCS. All of us know in the post PCI patients, we can add DAPT and we can continue it for the 6 months. And later on, we can come back to the SAPT, single antiplatelet therapy. And those patients who have atrial fibrillation, so we can give a single antiplatelet and we can add a novel oral anticoagulants at a lower dose. And those patients who have a high CHA2DS2, then we can give the NOAC at a therapeutic dose and we can hold the antiplatelets. So I intentionally put this slide over here. We know that many of our patients, due to multiple drugs or advanced age or lifestyle, they have a acid peptic disease as well. So those patients who have acid peptic disease or who are at high risk of GI bleed, so addition of the PPI is extremely, extremely important, and they are class 1 in the recommendation. Regarding lipid lowering agents, statin are the first line of therapy, and if the goals of the LDL are not met, then we can add ezetimibe against the class 1. And if the combination is unable to control the LDL level, like in patients with familial dyslipidemias, then the PCSK9 inhibitors, they can be added. So ACE inhibitors or ARBs, they are recommended in all those patients who have hypertension or diabetes or heart failure or combination of any of these along with the CCS, so ACE, ARBs are extremely, extremely important to improve the mortality. So let's move on. So what are the recommendations for the patients who have long-standing Dynaff-Corey syndrome and who are asymptomatic? Regular monitoring and periodic visits to the clinician, they are extremely, extremely important. And the role of FFR and role of CT and role of invasive angio, we have already discussed. I think at this time, at this step, we can hold for a moment. And if there are any further questions, we can, take the questions, I think, because, so anybody from the audience or from the panel, if there are any comments or questions, we can take the questions at this time, because main, guideline indications regarding the diagnosis and management that has been discussed. There is in the new guidelines, there was a slight changes, like there was a new addition of the indication of SGLT2 inhibitors. And for the patients who have CCS plus diabetes or CCS plus heart failure. So that was new in the guidelines. There are 2 or 3 slides as well for that. But I think most of other stuff has been summarized. So let's have some questions from the audience or comments from the panel experts. So Dr. Junaid or Dr. Saboor, do you have any comments?
Anjum, Rana, you have a very good presentation. You have explained in detail regarding the diagnosis and the management of the chronic coronary syndromes. Everything has been almost covered, but I will give few comments that we should have take-home message. What is your take-home message? What do you think that what few 2-3 things should be done for a patient with chronic coronary syndromes?
Okay.
For example, for the diagnostic point of view and for the long-term management point of view. Which test particularly you should advise, and then which other management plans you will advise is my question.
Okay, so that's an excellent question. Actually, there were recent the update in the ACC guidelines, the American guidelines and the European guidelines. They were updated almost 2 years ago. They were very, very detailed and elaborated. And the American guidelines, they, summarized the European guideline basically, and there were, total 10 summary was, it was summarized into total 10 steps. And in these 10
Yeah.
steps, 3 points which were highlighted or which were actually labeled as take home message. So I would repeat those, and that's my for me, that's also the take home message. First is uh, the lifestyle modification,
Mm.
smoking cessation,
Yeah.
weight maintenance, and changing of our daily activity, and the term which is used is decrease the sitting time. So this is extremely important in reduction of the risk in all these patients. So after lifestyle modification, then comes the turn of medication, and at last there is indication or there is role of revascularization. So even if those patients who are already on the medication and those patients who have already been revascularized, if we do not focus on the lifestyle modification, so we are missing a lot of the part of management. And I think you can see my screen, and this slide was already shown over there. So we see at the bottom there is a 10% decrease. 10% is a huge. So 1 out of 10, that is a 10% decrease in the risk of cardiovascular morbidity and mortality if we
Yeah.
decrease our sitting time by just changing our daily lifestyle. You can see
Yeah.
that chart, I think.
Yes, I think actually it's a team-based approach. Just like you say have a heart team. It's a team-like approach to the interventional cardiologist, the non-interventional cardiologist, and even the persons which are working in the diagnostic like echo, CT, MRI, and all they should sit together for this type of the patient, and then they should decide which important test we should do for these patients and which management plan we should go for that. For example, if we are advising for the medical management, the interventional cardiologist, the non-interventional cardiologist, and the diagnostic cardiologist, they all sit together, and they said that we have checked whatever the investigations are, and now this patient don't need any intervention. This patient not need further any testing, and now continue this type of the certain medication which you have explained it in a detail. All these medications should be given. So emphasis should be starting from that non-pharmacological treatment, and lifestyle modification and dietary plans. And if somebody is a smoker, you should quit the smoking. All these things should be considered, and these patients should be advised, follow up for 3 month or 6 month follow up. And at that time, again, a team approach should be there, that these types of patients, when different tests should be performed to these patients, because these patient has 50% or 60% disease, we are not intervening with them, and we don't want to go for the intervention. Then which further tests, like which either we go for the stress testing, either we go for the angiography or stress thallium after 3 months or 6 months. These should be in a team approach. That should decide the this type of the patient too, because all these patients are chronic coronary syndrome. इसीलिए बन गया ना ये असल में, इसीलिए बन गया है कि आप सारे बैठे and then decide कि which important test should be done for this patient and which further management plan should be given to this patient, including the lifestyle modification, dietary plans, and medical management, and all that.
Okay, there's a question from a participant.
Yeah.
Is there any gender difference in the diagnosis and management of chronic coronary syndromes? And since the epidemiological data Dr. Anjum Rana just showed it, it told us that there was a bit gender difference. So this is a question asked by a participant. Is there any gender difference in the long-term management and long-term management of chronic coronary syndromes?
Okay, so The question can be split into two parts. First is whether there is a difference in the diagnosis of coronary CCS in patients who are male or female. And the second part, whether there is a difference in the management in the patients according to the gender. So regarding diagnosis, if the symptoms are typical and if the age is 50 plus, that means post-menopausal woman, then the likelihood of presence of coronary artery disease is extremely high, and these patients can be subjected to invasive investigations. But other way around, if the woman they present with atypical chest pain and also the age is below 50, that means they are premenopausal. Again, in these patients, the likelihood of obstructive coronary artery disease is extremely low. And we saw in the chart we already shown it was 1 to 3%. That means very low. If it's less than 15%, we'll categorize it into a low risk category. So in these patients, these patients should be resorted to non-invasive investigation that may include stress testing using nuclear scans or stress echo. And another thing, which is regarding the difference in the management. So when we talk about management of these patients with the CCS, there is a more bulk of the women who present and are diagnosed with microvascular angina or metal angina. And if we, see the overall figures, when we do angiograms in these patients who present with CCS and who are suspected of having obstructive coronary artery disease, and we perform the angiograms. So the incidence of presence of non-obstructive coronaries, along with, although the symptoms are typical, so along with typical symptoms, but non-obstructive coronary artery disease on the angiogram. So the incidence of the non-obstructive coronary is higher in the women. And in these women, again, for diagnostic purposes, the workup of metal angina and the workup of microvascular angina, which we already discussed the modalities which can be used for that. So that should always be done in this woman to rule out, because the management is different when it's metal angina or microvascular angina or obstructive coronary artery disease. And in the past, there were studies where the hormonal replacement therapy was used in women in an effort to give them longer cardio protection, but in the current guidelines, it's a class 3. So there is no role of HRT or hormonal replacement therapy in the post-menopausal woman to decrease the morbidity or mortality or the burden of coronary artery disease. So by the guidelines, these are the major summarization in the gender differences. Regarding revascularization and drug therapy, there is no difference in the patients who are having obstructive coronary artery disease, whether that's a male or a female. The guidelines for the management are otherwise similar.
Thank you, Dr. Anjum. Let me ask you that, do you have more slides to discuss here regarding the topic, the actual topic?
So the main slides have already been discussed.
I think discussion is very good. Assalamu alaikum, everyone.
Walaikum assalam. How are you?
It was, thank you very much, sir. It was very detailed discussion actually by Dr. Rana, and he has given a whole topic of that. I want to have a few comments actually. One is the basic summary is that this is a chronic stable angina treatment actually, where myocardial oxygen demand and supply mismatch symptoms, they are being treated by beta blockers and nitrates and other drugs he has mentioned. And the other point is the disease modifying drugs actually. The statins he has not mentioned at all. I think he just had maybe in the next slides actually he has omitted. Statin, they have a role, and then as he mentioned that obstructive coronary artery disease and non-obstructive coronary artery disease, which is becoming more common in females, that is very important. Regarding as
so
Dr. Samoor has mentioned that there should be a plan for how do we go along with a patient who comes with chronic stable angina. And to me, the most important point is to categorize one patient into high risk and low risk patient or intermediate risk, actually, because low risk patients will be better off with medicines, and we have a lot of data on that. And high risk patients, they will definitely need intervention in the form of revascularization, whether it's stents or bypass or anything. So while we are stratifying these patients into high risk and low risk, we should not miss actually high risk patients who need intervention. And we should not, the intermediate risk where we have a little bit role to play, but the high risk patients, I think Dr. Rana will like to have a comment on that he mentioned medical treatment most of the times in this patient, but intervention guidelines, how the guidelines they are recommending intervention in high risk chronic stable angina patients.
So thank you, sir, for highlighting these two important aspects of management of the CCS. Regarding statins, I think we quickly discussed a slide, which is if the slide share is there, which you can see the slide. The statins are the class 1 recommendation we discussed for decreasing the morbidity and mortality in these patients. And if the goals of LDL are not met, then we can add ezetimibe and we can add the PCSK9 if the combination of the above two drugs is not able to achieve the goal. So statins, they were quickly discussed during the presentation, and they are extremely important, and because they have a morbidity and mortality benefit. So regarding second question, which is for which patients should go invasive workup. So we'll come to this slide we already discussed. So there was a slide on which a single guideline was put on for invasive angiography, and this is the slide. And we see that in all those patients who appears to have severe symptoms, who appear to have typical symptoms and which are present on mild exertion, that means class 3 or class 4 angina. Those patients who are refractory to drug therapy. So these are the three categories. And those patients who have, along with the angina, who have on echo, there's documentation of LV dysfunction. So those patients who have CCS plus heart failure. So these are the patients who are at high risk. And if we are doing a Holter monitoring, and these patients with CCS have episodes of malignant arrhythmias, which is sustained ventricular arrhythmias. So these patients are at a very high risk of future events and have increased cardiovascular morbidity and mortality. So all these patients should undergo invasive angiographic testing, as we see that the slide was on there. And ideally, if the patient never had an episode of ACS, so these patients should first undergo, of course, have an ECG and a serial troponin. And if all these are, normal and we are able to rule out ACS, so then we do an invasive testing. And in invasive testing, ideally in the latest guidelines, but the thing which was specifically added is that FFR or IFR, that means functional assessment capability, should also be available on site. And if there is a stenosis, which is like between 60 to 90%, IFR or FFR should ideally be done on that. And if there is a high-grade stenosis, as you see in this slide, 90% or more, then you have to revascularize there and then. But if there is a stenosis less than that, so for these cases, IFR or FFR can be done. And if the stenosis is less than 50%, then we label it as a non-obstructive coronary disease.
Dr. Anjum, do you have more slides to share, or are you done with your actual talk?
The presentation.
May I just add a point over here?
Yes, sir.
Yes.
Anjum, क्या हाल है? ठीक जा रहे हो? बहुत मुबारक हो firstly for your promotion and for getting into a new life. May Allah Ta'ala keep you all protected and into a better place. Indeed, a very nice presentation. Some of it I was able to listen to and some of it was not. For the benefit of everyone over here who is listening to it, let's talk about a little bit different. So you have your patients in which you have given dual antiplatelet. Patient has a problem. And then you start to say that he's not responding. So you start giving him, because of his ACS, you start giving him Flaxane or something like that. The LV is rather poor, and NOAC. And you say that, okay, now you have to watch out for the bleeding. What precautionary measures would you especially recommend the family regarding this person? How do you go about counseling the family over here?
Sorry, sir, there is a
I'd like to
lot of-
highlight this because what I normally end up doing is, you see, basically what I'm talking about is dual antiplatelet along with a NOAC in patients who are stable coronary artery disease with multiple problems. So what family teaching do you have to do over here? Any comments on that?
So any
Yes,
comment?
what I generally do is I ask the patient and the family to take care of the bleeding risk, actually, to tell them that you are at a relatively increased risk. And if you start like you are brushing at your teeth and there is some oozing of blood in your brush, actually, then it means it's, or if you are having a bruises, actually, with a light touch, you are having bruises. And number three is APD, actually, because this is a very common ignored thing, actually. So to look into the hemoglobin off and on. So these are 2-3 things actually which I generally say to my patients that because you are taking these medicines, so you are at a high risk of that. So please take care of this thing. If you are having these bruises or while you are having urinating, there is color change, or you are brushing and there is some blood is coming out of your gums, actually. So please come back and we will like to stop medicine or modify medicines.
There's a question from a participant.
Another thing over here that you may consider is that, you know, a lot of the economics of our travel, you have to explain to them and the family is that they must wear a helmet. You know, despite
yes.
whatever the government restrictions that there are, and because they can't afford private vehicles mostly, so you have to actually go about it. And then another thing is that you have to try and make sure that these patients retain their medicines properly. What actually many times these people end up doing is they take their medicine for a short time and then they go. And whenever these patients are asked to need another operation for whatever reason, because they are in that age bracket, so then you actually need to, I must say, Anjum, mashallah, very good presentation, and you covered all the points extremely well. Thank you. And Ahmed Bandeja Saab, good to see you.
Thank you, Umar. Thank you.
Okay, is there any comparison or comparative data available? Actually, this is a question from a participant for this invasive versus for this non-invasive testing, this CT angiogram and routine exercise tolerance test being performed. Is there any comparative data available regarding the risk stratification of chronic coronary syndromes?
Okay. So there is a, there is a huge, data is huge. So there's a lot of studies, there are a lot of comparative trial, there are analysis. So this slide is actually directly from the guideline, which is a medical analysis of several studies. And you can see the comparison of the stress ECG with coronary CT, PET, EMR, stress echo. I hope you can see on
Just show it out there. ज़्यादा खा लिया ना जगह नींद आ जानी नहीं.
Bilal sir, can you silence your cell phone? Bilal sir, can you
Bilal
silence your
साहब mute कर लें खाना खाते हुए.
Sorry, yeah, sorry, I know, sorry.
या हमें भी बुला लें खाने पे.
वो तो पीसीए बैग के खाना खाई जा रहे कल ही.
जी डॉक्टर
अंजुम मैं तो बुलाया थी तुसी आए नहीं.
जी डॉक्टर अंजुम.
Okay, thank you, Dr. Junaid, for asking this question. So this question is generally, it's a very, very important, question, because it's generally asked by the patients or the family that which test is best for us. Should we do an angiography or not? Should we get a CT or not? So there are two aspects. One is, the guideline based, and the other one is a practical based. So regarding guidelines based, so this is a guideline based slide, which is a summary of the meta-analysis of several randomized studies. And over here, as you can see, this slide compares the stress ECG with CT, with PET, with stress MR, stress echo, or SPECT. So we highlighted that if we go with the sensitivity or specificity of one of the tests to rule in coronary artery disease or to rule out coronary artery disease. So we have discussed these two things separately. So first we will see that what is the probability of any test to rule out coronary artery disease. What's the meaning of that? If we do a test and if the result is negative for obstructive coronary artery disease, for ischemia, so what is the likelihood that the patient will remain event free? So the CT has the highest reliability among all the investigations for ruling out. If the CT is normal, if the CT does not show a coronary artery disease or coronary artery stenosis of more than 50% among all these imaging modalities, so that gives us the highest likelihood, according to the studies, that the patient would remain event free. So if we compare it with the stress ECG, which is our ETT, you see at the top, the ability of the stress ETT test to rule out the presence of coronary artery disease is very, very less, even it's less than 50%. So the PET and CMR, they have a comparable, a big capability to rule out coronary artery disease, but slightly lower than the CT. Stress echo is again slightly lower, but its stress echo is better than ETT or stress ECG. So that's how it goes for ruling out. So for ruling in, what's meaning by that? If a test result appears to be positive for presence of obstructive coronary artery disease, and we do an angiogram or invasive FFR or IFR, on the top of the slide, you see the clinical likelihood of ICA significant CAD. That means after invasive angio, in these patients, when you do angiography, you see that one of the or more of the arteries has a more than 50% stenosis. So what are the chances of that? If the longer this red line, the higher are the chances the patient is going to have a significant stenosis on the invasive angio. So if you want to estimate or get an idea about the result of the invasive angio, without doing that, so the PET and the CT, they are at the top. So I hope that answers the question.
Yes, nicely answered. So there's another question that what is the role of triple therapy or triple blood thinner therapy in management of chronic coronary syndromes? The question is towards our panelists. What is your experience, current experience in managing your patients with refractory angina with triple therapy or adding anticoagulation or NOACs for the treatment without atrial
Okay.
fibrillation?
Okay, thank you.
जी बताइए अभी क्या तकलीफ हो रही है
So regarding the use of triple therapy, that
बहुत
means
ज्यादा हो ठीक है और राइट साइड रिस्ट पे बहुत ज्यादा ठीक है
okay, there is
और
some
घबराहट बहुत ज्यादा है
okay, regarding
चलना
the
फिरना कितना है चलना फिरना बाकी चलना फिरना जितना चल रही हैं वो चल पाती है
I think there is some noise.
Fawad, can you please mute your Dr. Fawad Farooq? Fawad Farooq, can you please mute your phone?
Okay.
Thank you.
Thank you. Sorry. So we were talking about the role of the triple antithrombotic therapy. So that means dual antiplatelet and an anticoagulant. So if we talk about the guidelines, in guidelines, if in patients with CCS, chronic coronary syndrome, which is a stable angina, and if the patients have an atrial fibrillation and the CHAD-VASc is 2 or more, so then in these cases, there can be a role of triple antithrombotic therapy. So if the patient, for example, one of these patients undergo revascularization, then you for 6 months you have to go for a dual antiplatelet. But if there's an indication for anticoagulant like high CHA2DS2-VASc along with atrial fibrillation, then in the first month of therapy, you can go with the triple regime. And after the first month, you can switch off one of the antiplatelet drugs, and then you can continue with one antiplatelet and one anticoagulation. And the anticoagulation of choice in those cases would be rivaroxaban. If it's used, then the dose would be low dose, 2.5 milligram twice a day. And if apixaban, that's probably preferred. And again, the dose would be 2.5 milligram twice a day. And if the patient has a recent thromboembolic event, like if the patient has a DVT or concomitant embolism or atrial fibrillation along with systemic embolization to the lower limb or someplace other than the brain, then in these cases, you can go with the anticoagulant therapy according to the guidelines. But again, the low dose is lower. The rivaroxaban should be given at a 15 mg continuation dose once a day rather than the 20 mg, which is the standard dose. So as such, to decrease the risk or morbidity or mortality of the CCS itself, there is no role of the triple therapy. But if the patient has another compelling indication for anticoagulation, so then it can be added for a shorter duration of time.
Okay. While discussing the different stepwise approach or stepwise up titration of anti-anginals for these patients, CCS, there was step 1, 2, and 3. So can we combine a patient? We can initiate a step 1 treatment and step 3 treatment concomitantly, just like we are treating our hypertensive patients. And from the very beginning, we are going with 2 drugs. Now the patients, instead of stepping up the treatment, can we combine 2 drugs just to know to give an early relief to the patient, or shall we have to strictly follow this algorithm?
Okay, if we get a patient who have a CCS and has a symptomatic CCS, chest pain, stable anginal chest pain, and the patient is also hypertensive, and the patient is also having a high baseline heart rate, so definitely we can individualize our decision making. These guidelines are there as this is basically the outline of the management according to the available evidence. And we can use these guidelines, and then we can use our clinical decision making in certain patients specifically and individually as well. So a patient who has a CCS, symptomatic angina, along with uncontrolled hypertension, and the baseline heart rate is also high, then we can definitely combine the drugs of our choice to address all these factors. So we can add amlodipine, we can add beta blocker there, and then we can add nitrate as well. And there is one way, if the patient is tolerating. So there is one approach which Dr. Junaid, you have mentioned, that is go with the maximum therapy, and then your downsize the number of drugs. So that's another way. So if the patient, you can see that if the patient's heart rate, blood pressure hemodynamically, if we can tolerate, so that can be another approach. That can be a reasonable approach for individual patients.
So, Dr. Junaid, I think we should wind it up.
Yes, thank you very much, Dr. Anjum Rana. Thank you very much, the worthy panelists, for sparing your precious time, and especially to our speaker, Dr. Anjum Rana, a very well prepared talk and quite comprehensive and organized slide scheme, ready to answer any bloody question with quite patience. Thank you very much for. I hope the participants have benefited with today's activity. The program is being recorded and will be available on the Pakistan Cardiac Society's web page series. Thank you very much. See you in the next session.
Thank you, Dr. Junaid. Thank you, everybody.